Hi, my name is Rian Chatterton, and I am a speech language pathologist who specializes in orofacial myofunctional disorders. I have been identifying and treating orofacial myofunctional disorders for over 12 years, and I am the owner of the Center for Orofacial Myology. So my presentation today is going to be about the impact of oral ties, tongue tie, restricted oral tissues, ankyloglossia, whatever term you want to use it. It just means restriction of movement on speech sound development. So there are three things that humans need to live and to survive. First, we would have food. Second would be water. And third, required would be breath, being able to breathe. So take a moment and think about, what do all three of these things have in common? During our live presentation, it was very interesting to hear different comments about the commonality of these three survival things that we have to have. But if we look at them, the thing that they have in common is that they require our mouth and our tongue. So when we are born as infants, our tongue almost has to have full functional use to survive. Many of the cranial bones and facial bones can take up to 18 years to fully develop. So it just shows you how important the mouth is and the tongue are for development. There are many different phases of speech development, and I just want to quickly kind of break each of these down. So between birth to 6 months, we have the pre-linguistic phase, which is where infants will start making sounds and responding to their environment, maybe start some cooing. And then at 6 to 9 months, they start to babble, which means that they start to produce repetitive sounds and syllables by playing with their lips and their tongue. At 9 to 18 months, we start to get that one word stage where we're just using one word. May not be fully a full word, but an approximation to a word. And then 9 to 18 months the 18 to 24 month would be our two-word stage, where we are starting to combine words together. At 2 to 3 years, we're going to get the telegraphic phase, which means we're using short, grammatically simplified sentences. And then we get into the multi-word stage, which is more of an advanced vocabulary, and we're starting to learn grammatical structure in our language. So what impact could tethered oral tissue or oral ties have on speech production? If there is lingual and labial restriction, it can really inhibit the full range of motion to learn how to produce specific speech sounds, especially sounds produced with elevated or retracted tongue positions, such as our sh, ch, k, and g sounds. So if a child feels discomfort, they are less likely to play with the oral movement throughout development, which then can start delaying from an early age speech production and speech and language development. It was interesting also at our live event that some of the doctors mentioned that pediatric patients hold on to trauma much earlier than we anticipated. And so if they feel a restriction, pain, or difficulty in any of these movements, it really will discourage them from wanting to play with the oral structure and the oral movement. So I want to have you try it. I'm going to have you read this paragraph, and we are going to pretend that we have a tongue tie. Now, the type of tongue tie that we're going to pretend would be a pretty severe tie compared to someone that maybe is not tethered all the way to the tip of the tongue. As you do this, I want you to think about a couple of things. First of all, do you feel any tension, any pull, or any pain anywhere throughout your entire body? And then what happens to your saliva management? the airflow of your speech production, and your speech clarity. So I'm going to read it out loud, and then I'm going to give you about 10 to 15 seconds for you to read it as well and to kind of reflect on these questions that I'm asking. So, racing rabbits ran rapidly around the rocky ridge, reaching rows of ripe raspberries. Rustling reeds revealed a rushing river, where reflections rippled beneath radiant rays of the rising sun. Relentlessly were the rambunctious rodents revealed in their remarkable romp. So, as I'm doing that, I'm taking the tip of my tongue and I'm kind of gluing it behind and on the bottom of my bottom teeth. So then all I'm having to do is use the posterior movement of my tongue and the blade of my tongue. So go ahead and take about 10 to 15 seconds to read that paragraph for me. During the live event, many of the doctors reported feeling immediate tension in the front of their neck, feeling immediate tension under the chin, feeling like one doctor said, I can't even move my jaw. My jaw is just kind of stuck. I don't even know what to do with it. So imagine being a pediatric patient and feeling that way. In my observation of the doctors in the room, I noticed that there would be mandibular protrusion. So all of a sudden, the jaw is overworking and into an unnatural position, causing stress on the temporomandibular joint and pulling that condyle forward out of the joint. So over time, what's going to happen to the jaw joint if the individual has to compensate by using mandibular forward sliding during their speech production? Other observations that I had when doctors were reading this was I saw a lot of cheek and lip activation that shouldn't be activated, a lot of tension and pain. They reported that their saliva felt like it was just building up in their mouth and they weren't able to kind of suck back and swallow and manage the saliva like it would. Other changes would be airflow. So you probably heard in mine, my speech started to sound a little gargly, or less intelligible or clear and crisp. So when I don't have full range of motion with my tongue, I might start producing different types of compensation patterns or placement patterns of my tongue, such as what we consider a frontal lisp on our S and Z, where the tongue comes forward intradentally, right? Fat Sally had cereal for breakfast. Or because I'm tethered, I might not be able to curl the lateral borders of my tongue up like I would want to produce my S, my SH sounds. And it might sound like there's air escaping on the sides. Sally had cereal for breakfast, because we don't have the range of motion that we need to produce those sounds. Over time, this can cause a lot of pain, tension, forward head resting posture. For our pediatric patients, it may start as mild headaches, and then into adulthood turn into migraines. So when we are looking at assessing functional range of motion, or when we do an assessment in our office to look for tethered oral tissue, we really strongly do not think that everybody needs to have a frenotomy or a frenuloplasty or a tongue tie release procedure. It is based off of 5 areas. First, we really just want to classify it based off of what it looks like. Second, we are going to look at the functional range of motion and determine how well the tongue is able to move in the mouth. Third, we're going to look for the compensation patterns like I just showed in my speech production. We're going to look for any tension or have the patients report any tension they feel throughout the day. And then the last one and most important are the symptoms that they're having. And those symptoms are a totally separate lecture. I'm not going to go too much into that. Um, it would take a lot of time. So I'm not going to go too much into that, but symptoms really dictate our decision on whether that individual needs to have a release or even be seen for therapy. So the first thing we look at is just the anatomical classification. We just say, what does it look like? This can be type 1 to type 4. And you can see here on the bottom, there is a type 1 lingual frenulum. I am not saying this is a type 1 tongue tie. Type 1 lingual frenulum, which is obviously connected all the way to the tip of the tongue. These are actual pictures of patients that we have seen in our office. A grade or a type 4 would be submucosal. You don't even see a lingual frenulum, but you do see a bowing of the tip of the tongue as well. Again, we're going to be looking at multiple things to determine, is this individual a candidate for a tongue tie release, or really there's nothing that would indicate other than what it looks like that there might be a little bit of tethered oral tissue. Type 3 would be more here. It's mid-tongue. You can still see that lingual frenulum. And then type 2 would be more of this tongue here with that lingual frenulum coming up and attaching, but not all the way to the tip of the tongue. Then we're going to look at 3 different functional range of motion movements. The first, we're just going to have them open their mouth as wide as they can. Without closing the jaw, we're going to have them try to touch to what we call the spot or the incisive papilla right behind their teeth. So they're going to open nice and wide and try to touch behind the teeth without closing the jaw. We would want to see about 75% or greater range of motion being able to do that without any pain, compensation, or difficulties. If we are at 50% or less, then we would make note that that would be a concern. Let's think about what speech sounds would be impacted most by not being able to elevate the tip of the tongue to that alveolar ridge or incisive papilla. So here we have the type 1, the trying to reach the tip to the spot or elevating the tongue is significantly low. So we're less than 50% range of motion. And so imagine this child trying to produce an L or an S or a T or a D or an N. So this is going to impact L, S, Z, N, T, and D production, which are all alveolar production and anterior movement of the tongue. The second motion that we have our patients do is we have them open as wide as they can and retract the tongue as far as they can back, trying to touch the soft palate. We would want to again see about 75 to 80% range of motion reaching to the soft palate. You can see here in this picture, this individual gets stuck at about 50%. Same with this individual is stuck at 50%. And this individual isn't even going to be able to retract the tongue back to the soft palate at all. So now I can see the type, and then I'm looking at functional range of motion. And the last one that we have them do is to just do a suction, which we can see here in this picture. They're going to suction up. And we're going to ask them again, like I asked you, do you feel any tension, pull, or pain when doing that movement? And if they do, I want to take note, where do they feel it? How often do they feel it? How severe is the tension and the pain? Have they had treatment for that tension and pain in the past? And a lot of people that come to our office can't even do that suction. But that suction into the soft palate is the natural tongue resting posture of infants. So if you slightly open the mouth of a sleeping baby, you would see the tongue suctioned into the palate. If it's not, it could be an indicator that there are some functional problems. Not necessarily tongue tie, but just some functional problems with muscle development and function. So if an individual comes to me that's even in their 40s, we get a lot of 40 through 60-year-olds that can't do that suction. It's just an indicator to me that they have not had their tongue in that resting posture for most of their life. So with suction, there are going to be specific speech sounds that will also be impacted. Our SH, our CH, our S, our Z, our J, multiple of our vowel sounds, and our R sound may all be impacted by not being able to do that suction. And then with the retraction, it may be that the R production is also going to be impacted. There are two ways that speech language pathologists teach the R sound. There's a retroflex R, where if this is my palate and this is my tongue, I'm just going to pull that tongue back and kind of curl it back to teach it. And then there's the bunched R, where again, if this is my palate, I'm going to pull my tongue up and back all the way in a bunched motion to that soft palate, making a good strong sound. But if again there's any restriction, pain, or tension when individuals are doing that, they may not find it possible to generalize those skills that they've had, that they've been working on in speech therapy for years and years and years. Okay, so what are the implications? First of all, the implication would be that they may have future risk of having temporal mandibular disorder in the TMJ. They may have neck pain, tension, and headaches. These individuals may be in speech therapy for a very long time because they're not being treated to treat the root cause of the problem. They're just being told how to do something, even though there may be a restriction prohibiting them from doing it. There may be a lack of generalization of speech sound acquisition. And then there's going to be frustration both from the patient and the family that they're not seeing continued progress with speech therapy services. The speech therapists themselves may also feel frustration because they're not making improvements with this child. By 5th or 6th grade, we should have most of our kids graduated out of speech therapy. So if they haven't graduated at that point, we may need to look a little deeper into what is the cause and reason for that. So I just want to share a case study that we had at our office. We had an 8-year-old female referred to our office by their speech language pathologist that they had been working with for years that just was not trained in orofacial myofunctional disorders or identification of tethered oral tissue. So they've been receiving treatment, trying to fix that R, and they just were not generalizing. They could do it beautifully in sentences, they could do it in reading, they could do it in very structured activities, but when it came to actually generalizing that with ease into conversation, it just wasn't happening. And the family was frustrated, the therapist was frustrated, of course the kid was frustrated because they'd been trying so hard to correct the sound. So when they came to our evaluation, we did notice that there was a posterior restriction, and it had been identified as well by their dental provider, because speech therapists really shouldn't be diagnosing tongue tie, but can help in the identification and recommendation for treatment. So the family decided if they're going to go get a tongue tie release or a frenectomy, frenuloplasty, kind of depending on what you're familiar with calling it, that they were going to go to Dr. Richard Baxter, who wrote the book Tongue Tied. They just wanted to make sure that they were going to a provider that they trusted and that they knew would do a great job. So it was pretty exciting because the individual's dad, who is also in the medical field, really did not believe in tongue tie and had a little resistance for some time until some encouragement was given and education was given. So when she returned back to our office, it was amazing to see that she did not need us anymore. She obviously was going to continue some myofunctional therapy to help her progress through her healing process, and to ensure that she had good function and tongue posture, but her R production corrected on its own. She really only had a few sessions, and then it generalized beautifully. So it was fun to see that it really was, she had learned the muscle memory for the R production, but because of her restriction, it was not allowing her to do that easily through generalized speech production. So I hope that this presentation has helped you see that although tongue tie is a hot topic right now, and there is a lot of speculation that people are just doing it for the money, we see every day in our office people that lives are fully impacted by having tongue tie releases done. We have not seen complications with doing this procedure. And again, we are doing a full comprehensive 5-step evaluation before we are going to recommend any type of tethered oral tissue release or identification. We encourage that we start looking at the impact it can have on speech production, and we start looking at what the root causes of these prolonged speech impediments may be. Thank you for your time today, and I hope you have a great day.